Are we streaming live?
Almost done.
Ganesh?
About to go live. We are live now.
Okay. So we'll just wait for half a minute and then we'll start with the. Okay. Yogita, you can take down the poster and I'll begin my introduction of Dolly. Very warm welcome to you all this evening. Hi, I am Jaya Jairam. On behalf of Mohan Foundation and NATCO, that's Network and Alliance of Transplant Coordinators of India, it is our proud privilege to welcome Dr. Uma Ali, an eminent pediatric nephrologist, to conduct a masterclass on counseling skills in pediatric transplants today. Dr. Ali has made remarkable contributions to pediatric healthcare, including the establishment of pediatric dialysis and transplant services at 3 hospitals in Mumbai, that is the BJ Wadia Hospital for Children, SRCC Children's Hospital, and Leelavati Hospital, all in Mumbai. She also played a pivotal role in setting up Mumbai's first large pediatric intensive care unit at BJ Wadia Hospital for Children. A dedicated mentor, Dr. Ali has trained numerous fellows in pediatric nephrology and intensive care, shaping the next gen. Her unwavering commitment to equity in healthcare and education ensures that quality care is accessible to all. Beyond all this, Dr. Ali is a founder member of Kidney Foundation for Children, an NGO committed to addressing the needs of young patients with kidney ailments. The process of counseling and supporting children and their families is uniquely complex and requires a nuanced and compassionate approach. So today, it's our proud privilege to have Dr. Uma Ali amongst us and to share her insights on how to navigate these challenges with empathy. And so please join me in extending a very warm welcome to Dr. Uma Ali. Over to you, Dr. Ali.
Yeah. Thank you very much, Jaya. Obliged to Mohan Foundation and to you for inviting me. I found the talk a little challenging. It's not something I normally talk on. It's outside my realms of academic talks. So I had to think a bit to say what.
Mhm.
And then you have, I think, we have a major group of transplant coordinators and some doctors. So without wasting time, I'll share my slide and then we'll
Yes.
begin. Yeah. Yeah. Can you see the slide?
Yes, Dr. Ali, can you just put
Yeah.
it on? Yeah,
Okay.
perfect,
Okay.
perfect.
Right. Okay. So I think it's a very important topic to think about and work on is how should we be counseling and what are the skills needed for counseling for pediatric kidney transplantation. And to be honest, I must say right at the beginning that doctors are not the best counselors. So amongst the various people who the patients deal with, perhaps doctors are the poorest of the counselors. And I'll come to that a little later. So, what we do see when we see a child with kidney disease is somebody on the left hand side standing alone on what looks like a flowerless, green, non green, barren land, and looking on the other side where there are lots of sunshine, greenery, happy children, and wants to go there but does not have maybe a very slender kind of bridge to cross, and the child is and the family is too scared to step over there, and so you find that they disappear from the scene and do not want to even make the attempt to go to a happier place. So the role we have over here is to build a bridge, not a slender just wooden plank, but a solid bridge which the parents children will not be intimidated by, and will be able to cross over and go to the other side where they can have a chance of a better life. So, to do this, we actually work, it is actually a bridge from hope to reality that we are building. And we have a team, the people most closely connected who can make this possible is the nephrologist, who usually is the first one to see the child and decide what is the best option medically for this child. Of course, the transplant surgeon, without whom we cannot take this step at all. And we need the family's full cooperation, understanding, and desire to move forward in this direction. And to make all this feasible, we have the transplant coordinators who are the binding cement of, you could say, all these three other people and the process to make it possible. So, what do we need to guide the family through? One is the medical aspects. They need to understand what we are suggesting, because none of the families come with any clear ideas of either chronic renal failure or transplant or the outcomes. So that is something which is largely addressed by the nephrology team. But there are several other aspects, and these are actually the ones which serve as, which work as barriers towards transplant. That's the emotional aspect of the family, which we deal with, the family of the child, the logistics, the practical aspects, the legal aspects, and of course, the financial aspects, always important in our country. Now, the basic knowledge which one needs before counseling, because I understand that a lot of coordinators are not coming from a healthcare background. They come from different backgrounds. Some may be from nursing or medical background, but a good number are from not healthcare backgrounds, and they enter into this field, and of course they are trained for it. But some things which we need to know, although it's not the kind of the requirement for the coordinator to convey all this, because these are usually conveyed by the doctor. But it's important to have a working knowledge of all this, because patients do not discriminate who they are asking what question. And they're likely to put the same questions which they've already heard the answers from the doctors to also the coordinator. So it's important for them to know about all this. So, one is about what the kidneys do basically, what function do they perform, and what happens in kidney failure, about kidney diseases of children in particular, and briefly about the transplantation process, the surgical aspects, the nephrology aspect, the pre-transplant, post-transplant expectations. And of course, something very important for counseling is to understand the socio-economic, cultural, and educational background of the family we are dealing with, so that what we talk to them is appropriate for them and not inappropriate. And as well, it's important to identify the decision makers in the family, which sometimes are not the parents, maybe the grandparent or the elder brother of the father, etc. So, these are important because then one can make a plan around this of how we are going to talk, to whom we are going to talk. And as the counseling is not just a one time event, it's going to be a series of meetings and talks, one could plan it accordingly. Now, briefly about the medical aspect, what we know about the kidney is your cleaner. It's in the lowest order. It's not like the brain, the heart. Nobody thinks a second thought about it. But you know what happens to your house if your domestic help doesn't turn up. It's all a big mess and everything is dirty and it needs to be cleaned. So that cleaning work and keeping the body uh, with the right amount of water, salts, chemicals for good functioning of the remaining organs is the function of the kidney. And to do this, the kidney has filters. So these are something like this, like a C. And there are about 1 million filters present to do this job. And what the kidney does is, as the blood flows through these filters, it pulls out the extra water, extra sodium, various other chemicals, urea, nitrogen, etc., which are in excess, and throws it out in the urine. Now, this work, our domestic help comes once a day at the best to do the cleaning, but the kidney works 24/7 and cleans the entire blood volume about 30 to 50 times in the day. So it's a continuous process and it never stops doing this. Now, what happens when these filters are reduced in number, either because the child is born with smaller kidneys, so it doesn't have 1 million nephrons and 1 million filters, but a fraction of that, or these filters are destroyed because of disease like glomerulonephritis, repeated urinary infections, etc. Then these filters become too few. So what happens? The cleaning of the blood becomes slower. The kidneys take longer to clean the blood, cannot remove all the waste products, and instead of 30 to 50 times, just about able to do it 6 to 7 times in the day. So all this leads to accumulation of various things. Some of them are water, various salts like sodium, potassium, phosphorus, various acids, other waste products like urea, creatinine, uric acid, and many others which we don't measure. And all this leads to various things that happens to the child. That's swelling over the body, there's high blood pressure, there's anemia, there is deformity of the limbs, short stature, bone deformities. So various combination of this you may see in different children with CKD. Not all may have all aspects of it, depending on when you're seeing the child. Now, which are the common conditions that lead to kidney failure in children? Now, in adults, there are two main culprits, diabetes and hypertension. These are not the culprits in children. So that is one important fundamental difference of what leads to renal failure between children and adults. And leading the list are congenital anomalies of the kidneys and urinary tract, which we collectively call CACUT, CAKUT, CACUT. So it involves a number of anomalies which may be present right from birth. The three key players here are posterior urethral valves, where there is obstruction to the passage of urine from the bladder. There are valves present, seen in boys. And because this blocks the outflow of urine, there is back pressure which harms the kidneys. This can be detected by antenatal sonography usually. And other important condition is a reflux nephropathy, where there is no block to the passage of urine, but the urine goes in a reverse direction back to the kidney, and this leads to urinary tract infections, damage to the kidney, and many of these children, the kidney itself may not have developed well at birth. And the third group is you don't find any such abnormalities, but the kidneys are small. They just have not developed at birth, and they are small hypoplastic kidneys or dysplastic, meaning the development has gone in a wrong way. And this is also a common cause of renal failure in children. So you could say collectively, these congenital anomalies account for almost 60% of the children you will see with kidney failure, something they are born with. Another important group is glomerular disease. That is, some of the nephrotic syndromes which come with swelling all over the body, protein leak in the urine, which don't respond to treatment or which have a genetic cause. These may progress to chronic renal failure over time. And you have many varieties of glomerulonephritis, some of them which resolve well, don't go into chronic renal failure, and many others which may over time slowly, insidiously progress to kidney failure. Okay. You also have an important group of hereditary diseases. This subset is important in children now with increasing availability of genetic tests. We are able to identify more and more of hereditary disorders, which may lead to renal failure. And then you have an assorted other group where children who earlier have had acute kidney injury may not have recovered fully, go to chronic renal failure, conditions like hemolytic uremic syndrome, or tumors of the kidney like Wilms tumor if it is bilateral, etc. So these are the major groups of conditions that lead to kidney failure in children. Now, the kidney failure does not immediately mean that there has to be dialysis and transplantation, because when the kidney function is low but still above 20% of its normal value, the child can still remain reasonably well, provided he or she is put on an appropriate diet and right amount of medications which need to be monitored periodically. However, when the kidney is doing less than 10% or 15% of the function, the child cannot remain well on diet and medications alone. Gradually you'll find that the biochemistry is not under good control and everything else is getting affected. So at this point of time, the child will need some support for the kidney, and this is in the form of either dialysis or transplant in order to remain well. Now, is dialysis a good option? Now, dialysis is a temporary solution. It cannot be continued indefinitely in children. As opposed to adults, just as an example, if somebody, say 50 plus, gets kidney failure, they can remain 15 to 20 years on dialysis if they don't want to go to transplant or they don't have the option. But we cannot keep a child 15 to 20 years on dialysis, because an 8-year-old will become 28-year-old as a young adult and with no future. And dialysis replaces only 20% of the kidney function. And as you can well imagine, the child is coming to hospital 3 times a week. Everything gets disrupted, the school, education, activities. So these are greatly interfered with, and some parents, hats off to them, still manage with the education, but not all do. There are many dropouts from education because of this. And it also imposes on the parents' time, because either they have to lose work or they have to find somebody else who looks after the house for them, depending on their role in the family. Important is mortality on dialysis is much higher than mortality on transplant. So that is an important thing to remember, that the chance of the child dying on dialysis is much more. A very important point which we don't pay much attention to because of logistical issues, that children should receive dialysis in a dedicated pediatric dialysis center. This is the first statement made in the UK British guidelines on pediatric dialysis. Unfortunately, we do not have so many pediatric dialysis centers. There are very few which can give good quality dialysis dedicated to children. And as such, giving good dialysis for a child is a challenge. Now, transplantation, as we all know, involves surgically placing a new healthy kidney in the child. And it provides, obviously, putting one kidney there. So 50% of the function is automatically replaced. And that's a good amount to live a healthy life without requiring any dialysis, etc. We cannot underplay the seriousness of the surgery because it is a supramajor surgery. It has potentially problems which could take place. So in counseling, one should not underplay it, even if the center has had many successful surgeries. You have to point out that there could be problems. However, one can quote the data from the center to show how many have been successful, and have to assure the parents that the transplant surgical team is an experienced team, has the required abilities and all the necessary other infrastructure needed to give it success. And that nephrologist will play a role by taking responsibility for the care of the child before, during, and after transplant, and ongoing till the pediatric age group. And we also need to impart, if most of this is already told to them by, as I said, by the nephrologist, but parents will still ask the same questions, and one need to address that the usual hospital stay will not be more than 2 weeks unless there's a problem. 5 days, 3 days, or 7 days in ICU and then in the ward, and can be discharged. But of course, child will need medications, regular checkup tests, and some of these medications are lifelong medications. The question then comes that how does the child get a kidney? Who can donate a kidney? That again, parents need to be advised that anyone who has a matching blood group, who is healthy, whose age between 18 years and 55 or 60 years, has two healthy kidneys, who's not diabetic, has no chronic disease, can give a kidney very well and keep very well subsequently without any shortening of their lifespan or the quality of life. Generally, for children, the donors are parents or grandparents because usually the siblings are too small, below 18 years, and they are not potential donors. So, the important thing to emphasize is we all have two kidneys. We don't normally use the full capacity of the kidney. Both kidneys are normal and have good function. We can happily donate one kidney and live our life without any problems. And that a full checkup would be done of the entire system and body of the donor, potential donor. And only if everything is okay is the donor accepted. And generally, donors do live a normal, healthy, long life, and it's not hampered by having donated a kidney. And we can give examples of many people who are born with a single kidney. There is a fair number who from birth have a single kidney. They do not have a problem. Nobody knows they have a problem. But for some reason, maybe in their 30s, 40s, somebody's asked for an ultrasound for some other reason. And it's incidentally detected that this man or woman has only one kidney. And then they undergo testing and find that everything is normal. So it tells us that even if you have one single kidney, but that kidney is a healthy kidney functioning normal, you can live a perfectly normal life. And that is the basis by which we can have a live donor kidney donation. Question always comes, they will always raise this issue of unrelated donor. And we cannot be ambiguous about it. We have to have very clear that why would somebody, if you are hesitant to give kidney to your child, why would somebody who's not related to you want to give their kidney to your child? You know, and some hesitation, this thing you eventually lead up. They would say you would guess it, and they would say it or not say it. It is with an exchange of money, and one has to be clear that that is illegal and there is a fairly severe penalty for that, and that no good transplant center would entertain it. We all know it's been done somewhere or the other, but then those transplants done at such centers may not have very good investigation, may not have very good checkup of the donor. It would be a poorly matched donor because it's not related, so long term outcomes will not be good. And there may be no follow up at all in that center after the procedure. So there are many hazards to it, even if they want to venture without your help to some other center. Once a topic is brought up, the harms of that need to be pointed out and a clear no to an unrelated donor. Okay. So this is what you're going to face, that you have somebody who has heard now so much, been told so much by the doctors, by his relatives, by the family, everything, that it says, okay, I'm ready to give medications to my child, but no dialysis, no transplant. Or they may say, okay for dialysis, but no for transplant. Or okay for transplant, but not for a living donor transplant. I can't donate because I'm the only earning member. I have two more children who look after them. I want to donate, but my father will not allow me. Can I try Ayurveda, Unani, homeopathy, or any other system? Or they will go with or without telling you to a Jyotish or a godman and try to solve all this without going for transplant. Because the misinformation in society regarding transplant, etc., is quite high. And there are any number of people advertising all over saying that they can cure everything from cancer to epilepsy to kidney disease to everything with some magic herb and mantras without any need for dialysis and transplant. We read it every day. Okay. So they also read this and they want to believe it. So this is where you're going to begin your counseling. The earlier was your background knowledge already explained to the patient by the nephrologist, but may crop up during your conversation. So you need to be prepared for that. So we already said we have to guide through the medical aspects. I don't think as a coordinator you need to begin with the medical aspects, but just be ready to address if needed while not going into its depths. Tell them that they can discuss it with their doctor if they ask any deeper question. But the misconceptions which they may bring up, you can surely clear those aspects of it. The important thing that you need to address is the emotional aspects, the legal aspects, the logistics, and the financial aspects. Okay? Now, when we speak to anyone, there may be three ways we are going about it. One, we may be just giving information, or we may be communicating, or we may incorporate counseling in it. And this is where it's important to understand the difference and plan our conversations accordingly. Very clearly, giving information is not communication. And this is what you hear, like in railway platforms and airports, they announce the departure of train or plane. It's a one-way information that you get. Yes, you need it, but you cannot communicate or say anything back if it's delayed. And believe me, usually this is what the approach doctors take. It's a one-way traffic. They'll give the information and they feel they've counseled. Okay, because they've shared whatever they think patients should know and understand about the medical surgical aspects of it. And generally, they are rushed, busy, they have other patients to attend to, many things. So the amount of time they've given to this is enough to convey the main medical aspects of the transplant. So all the others left to the coordinator to deal with. Now, when we say that we don't want to give information, it cannot be a one-way process, this important thing. It has to be communication, which is a two-way process. And by definition, what is communication? It's when both share their thoughts, ideas, information, opinions between two or more individuals with the purpose of building an understanding. So the communication has to uh, thought of as you're not going to be a one-way information supplier. You want to know what the family is thinking, what is their thoughts, what are their worries, what are their concerns. So it has to be a two-way process. So how do we make this communication effective? Because this communication is not like a social meeting. We meet friends, we meet family at home, at functions, and we chat, both parties chat, exchange information and whatever has happened. But it may not be effective. It is just a social communication that is happening. But here we have a goal. We want an effective communication which will lead the patient's family towards a decision which we think is probably best for the child. Okay, so this is a communication which has to be artfully negotiated by the coordinator so that it leads to where we want it to go eventually. Now, to make the communication effective, there's some basic requirements, that this conversation has to be in a place or a room where there's privacy. You can't have people coming in, coming out while you're talking to the patient. You have to allot enough time. So depending on whether this is your first time you're talking to them are there, you can decide how much time it'll need. Have to have comfortable seating arrangement. It can't be that one is seated, two are standing, etc. Very important, avoid doing any other work at that time. The family should not feel that this is just one more thing you're doing. They have to feel that this is the most important thing for you that you are doing, is talking to them. Switch off cell phones, don't receive calls, don't allow it to ring, keep it on a silent mode if you have not switched it off. For that 20 or 30 minutes which you're giving the family, they should be the only people who matter. This is very important for them to get the confidence that you care. Because if they don't feel that you care, you're just one more person who's talking to them and just telling them what you're supposed to tell, it will not have the effect which it needs to have. So, how do you start a communication or a conversation? You begin it by active listening. Okay. The most important part of communication is you're a listener, not a speaker. And it's an active listening. Active listening means while they are talking, verbal, non-verbal, eye contact, you give them the feel that you're interested in what they're saying, you're concerned with what they're saying, you understand what they're saying, and you have empathy for them. So many times it's not what you say, but the way you speak it that registers with the patient. What is the voice in which you say spoken? Did you make eye contact, or you were busy something writing on the desk and listening to them? What does your facial expression say? What does your bad body language say? And the feel they take back is only from the words 7%. The majority is from your facial expression, eye contact, and your body language. So that is why it's important to put away the other distractions and work which you have to before or after, and listen to what they have to say. And a good way of starting, because there's something family wants to talk about always, is how did they come to know the child had a kidney disease, what led them to that discovery, and what was their journey after, what was their feeling when they came to know, what was their journey after that, and how did they land wherever they have landed, to the hospital or center you're working in. And so that gives them makes them a little easy to converse, gives you time to understand where they are coming, so your subsequent way you talk to them can accordingly alter. Okay. Now, the role of a coordinator is also the role of a counselor. It is not just effective communication. What you want to do is also to assist, to guide, to identify the problems and help in finding solutions. So you're not just talking, okay, I understand, I understand what you went through. I've had some experience in a different situation like this, or quote somebody, you may share some anecdotes. But your story, your goal doesn't end there. You want to guide them. They have a whole lot of cobwebs in their brain, which they come and which you can make out by the way they talk, that they keep repeating the same thing. And what you want is to unravel this into a nice, smooth bundle where the wires are not crossing each other, but they can themselves get clearer in their thoughts and more focused. So you have, for as a counselor, you have to interrupt this conversation with intelligent questions. Otherwise, your full 20 minutes will go with their telling their story. Okay? So you have to plan that when will you put your questions and what questions will you put. And you have to also share some information which you have, which they do not have, because of which they have misconceptions regarding the whole logistics process, other people who have gone through similar things, the anecdotes from them. So there may be different tidbits you will have to share, not as a lecture, but as pieces of information interspersed in the conversation, so that they become clearer and clearer and unravel the cobwebs. So some of the things which you will need them is ask them, what do they know about transplantation? How did they hear of it? What is their understanding? What did they know up till now? While they say correct misconception process, if you feel they've not understood it, point out the advantages of transplantation over dialysis, the safety and satisfaction of live donation. Ask them what are their thoughts. How have they thought about it? Have they discussed at home? Do they have any concerns? So that way you will know what they are thinking and be able to counsel them. Periodically, you may have to paraphrase it. That means whatever has been discussed has been very randomly put as various pieces of jigsaw puzzles. You need to get them together and say, okay, so what you say is that you went through a hard time and a shock when you learned about the kidney disease. I can understand that, because not many people know about kidney disease, and kidneys manifest only when 80% of the function is lost. So you are not unique in the situation. Other people who've gone through have had similar experience. You could quote if you have somebody else who faced something like that in your patient cohort, and tell them, and you are not as yet sure whether you want to go for transplantation, or depending on what they say, or you want to go for transplantation, but you're worried about 1, 2, 3, 4. So make it a more, now by paraphrasing, focus to the main things which you would need to address and they would need to address. Okay. Some of the useful tools while counseling is, if you have videos of children after transplantation going to school, taking part in sports, or winning prizes in some activity, so just participating in annual day functions in school, show them those videos, so that will break your conversation monotony. And also, you know, pictures speak louder than words. So what you see is more convincing than whatever we speak. You could share videos of donors, live donors who are willing to share their experience. You can yourself quote anecdotes. You can offer to connect them to an organ donor if you've already identified one who's willing to talk to a new family, because there are many people who are, having gone through the process, in a much better position than you and me to talk to a future donor. And there could be support groups which you could ask them to contact, speak to, so that they get from other families the feedback which they are likely to believe much more than they believe the doctors and hospital healthcare workers. So it boosts whatever you have said will get supported by these people. So the idea is that a good communication has to be not just a data transfer, that you have so many things to say and you will tell them all that. It has to be something which addresses what they need. So they're going to be anxious. So it has to address the anxieties, that the anxieties are not unfounded. We cannot say that, discount the anxiety, that unnecessarily you're anxious. They're necessarily anxious. That anxiety you cannot run away from. It's a very major event which has happened, an adverse event, and they have to cope with it. You have to accept their anger, because if they've not been able to vent it earlier, they will say how they were let down by this or let down by that and were wrongly guided or whatever. But you have to understand where that anger is coming from and not respond it as anger to anger, even if it's somewhere directed against us. And you have to, at the end of it, they have to feel that you're somebody they can trust, you are somebody they can believe, and they will develop a faith in your abilities and commitment, that you are committed to their care and you are capable of doing it. So this is what you should be able to achieve when you meet the family, that they now trust you for all their future questioning, guidance, etc. So when you counsel, you're looking at two things. One, that you begin with an active listening, which is putting up a question to them, which allows them to talk, to vent, say what they want. And you're looking at trying to see how they're going to respond to all this. And what you want to look at is, you want to focus is decision making and problem solving. As we said, this is not just a social communication. You want to see what are their problems. You want to help them to solve it, so that they will resolve their own problems with your guidance and help them to make a decision and guide them towards the right way, which would be helpful to their child. So to do this, you would have to intersperse your active listening and the empathy with intelligent questioning, so that it comes to the point which you want to bring it to. And above all, it should not be patronizing. It should not be like, I know more than what you do kind of thing, and you have to listen to me. It shouldn't ever give that kind of a feeling. Okay? And I'm not going to go much into disease donor counseling, but very important is that because different hospitals have different setups. If you do have a social worker in your ICU who spends time with the families, not only families who are terminally ill, but all families who have their loved ones in the ICU. Then you have some helping hand because they are there to help them through the grief as grief counselors. But if your hospital does not have that, then probably the task would come on the transplant coordinator to perhaps take ICU rounds every day to know who are the patients, interact with all the patients, not necessarily those who are, on the deathbed. And should one of them happen to pass away and is a potential organ donor, first allow them to grieve, give them privacy, give them time. Once they've accepted the reality of death, then one can broach the topic whether they would like to donate organs of their loved ones, because it can save other lives. And although the child may be gone from this world, some part of the child lives on in somebody else. And this is something today I find many parents would like to do it despite their sorrow. So this is a very delicate area, and we have to have a lot of maturity how we are going to handle it. And it's always nice to be seen as part of the ICU and not somebody who comes only when there is, a death that has happened. Especially if you do not have another counterpart who's handling that aspect of it. If you have, then probably they'll call you only to counsel the parents regarding the transplant. So this is what you started off, and one by one you have to get rid of all these thoughts which we do not want, which is hampering their way to the path, and lead them from this confused, horrified state to a thinking process and then a solution process. So guiding them through these stages, it may take longer in some, shorter in the others, the task which we have in front of us, so that the coordinator becomes the family friend of the family, and they look upon the coordinator, the person they can turn to for any question, any problems that they have in the logistics of transplant. So from this kind of area of where the child actually ran away from, what we are looking at is building a bridge, giving supports, showing that people cross across this bridge safely so that the child and family may also venture across the bridge and reach the other end. So thank you. Any questions, discussions we can have. So I just briefly put through some of my thoughts, which I felt are important in counseling for pediatric transplant.
Thank you so much, Dr. Ali. You simplified the complexities of, what the children and parents go through in such a simple manner. Thank you so much for that. If any of y'all have any questions, please go ahead and unmute yourselves and y'all may ask.
Yeah, I think there are a few questions on the chat
Yeah,
box.
let me just read that.
Yeah.
Somebody wants your PPT. They say PPT is very creative and highly informative. So,
yeah, I can share it. That's not a problem.
That's wonderful.
I can share it with you, Jaya, and you can share it with
I'll
whoever.
happy to do that. Rajeshwari says she was born with small kidney reflux nephropathy by birth. Oh, wow. And Rajeshwari, did you have to undergo a transplant? You could probably, she says to share her story with parents with photographs to break the myth about life after transplants. Wonderful.
Hello.
Yes, Rajeshwari?
Hello. Hi, ma'am. I'm Rajshri from Kidney Education Initiative.
From where? Sorry?
Kidney Education Initiative.
Okay, welcome, Rajeshwari.
I run a project with pediatric nephrology kids, or pre or post transplant, or kids on dialysis or offer on dialysis, or OPD kids. So those who are not are able to attend school. So specially designed program. I designed this program because I faced many challenges while I was in school. So I have empathy for all the kids, and so I decided, and today I completed 1 year in my program.
Congratulations, Rajeshri.
Yeah.
I'd love to connect with you. So please do reach out to me. I'll share my email here. We'd love to stay connected with
Ma'am,
you,
I have one
Rajeshri.
question.
Yes,
Sure, ma'am. I have one question. I
please go
have two,
ahead.
three kids. In my session, they come always, and I also talk with parents about my journey and my school days and how I gone through and what my mother faced and how she handle everything because I am a single. My mother is a single parent, but still she managed everything. So I always spoke them about my story, but here what I felt is that family pressure. If one kid is not healthy, right, and he or she is on dialysis, then the mother is pressurized to have another kid. That let him, he or she die, or we are not ready for transplant, or we don't want to go for it. We will keep a kid on dialysis, and you have to when you try for another kid. So this is what I come to know while I'm working with parents and especially I'm talking with mothers. So in this situation, how we can help them?
Dr.
Yeah.
Ali?
I understand it's like a
See,
gender and socio-cultural, gender bias, a little little tricky.
this is Rajeshwari, not an uncommon problem and
Yes.
attitude, and sometimes even though the parents themselves often do not look at it that way at that point of time because they're attached to the child they've given birth to,
Hmm.
etc. But the extended family, grandparents, aunts, uncles may all think that way. Oh, you can have another child, let this child go.
Hmm.
What's the use? I
Hmm.
think the thing is, we also, as a medical community, in even pediatricians, uh, still a long way to realize that the family is not our patient. The patient is the child. We are
Yes.
committed to the rights of the child, and every child
Hmm.
has a right to live. Okay,
Hmm.
right to live, right to a healthy life, and it's not for us to decide whether living 10 years more and 15 years more
Hmm.
uh, is inferior to somebody who lives 70 years of
Hmm.
life. For somebody in 10, 15 years of life may do a lot more than somebody who's lived 70, 80 and done nothing much at all. So that's a
Yes.
very subjective thing. And we have our
Yes.
own stories and mythology that of uh, I don't remember very clearly of this boy who was uh, supposed to live only for 16 years, and the mother was given the option that either she'll have a very intelligent, good boy who live only till 16 years or somebody who live longer but not be as good. And she chose the 16 years. But in the 16th year, when he was to be taken away by Yama, she didn't want to part with him. And then, with the prayers and everything, she got his life extended. So
Hmm.
we do have, so obviously, these has come out of situations of a different kind, these stories in those days. So it's difficult to work through this, but it's our duty to try. Okay.
Yes.
And we
So
do
I'm
find
trying.
that parents do change them, not change their mind, but stand up for the rights of their child. I'll give you a small
Hmm.
example. One of my earliest transplant, this was a child, not only kidney failure as an infant, but a child with other deformities as well. Okay. Not
Hmm.
a totally normal child.
Okay.
But they wanted to do everything. The child went on dialysis, and then they were finding dialysis very difficult. She was on CAPD at home, but still the cost and various
Hmm.
other issues. And they wanted to go for transplant. Hmm.
Hmm.
Now, the father was a very different man, very emotional man. Both he and the mother had matching blood groups with the child. He came and told me, don't ask my wife to donate. She'll take a long time to think, decide. I'm willing to donate. Take my kidney. So we were
Hmm.
walking him up, but the law requires that we need a consent from the donor's family, not the spouse. So we had to
Yes.
involve obviously his parents, etc. His
Hmm.
mother, she was, one of those Lalita Pawars of Hindi film. She told her
Hmm.
daughter-in-law, if you make my son give his kidney, I will drag you by the hair in the middle of the road, and trash you. So thank God for some time it died a natural death, but they still wanted to do. And one day, this meek man, who was, very emotional, would cry, etc., told his mother that just like I'm important for you, my child is important for me. So
Yes.
I want my child to live, and I'll give my kidney to the child, whether you agree or you don't agree. And
Hmm.
then the grandmother had no option, fell in line, etc. Because somewhere
Hmm.
we have to support the parents to take a stand on this matter. We can't just
Hmm.
directly tell them to oppose, but we have to say that their responsibility and duties towards the child whom they've given birth to. It may
Dr.
succeed
Ali, we
sometimes, it
have
may
one
not.
more. Sorry. We have another question from Jyoti. While counseling for transplant, how to, as what extent should the parents be counseled regarding possibility of complications?
I think you have to counsel them for the complications, because the legal counseling session is all about telling them everything, which is video recorded. So you tell them the procedure, you tell them whatever's the possible immediate complications, subsequent complications, the possibility of rejection, possibility of infection. And also at the same time, you tell them what we will be able to do about it. And that there are some things which are beyond our limit, but this is the best we have in science today.
Yeah.
So
Any
it's
other
important
question?
to mention.
Yeah.
Yeah.
Any other questions? I see some hands have gone up. JSS Hospital.
Yeah, hi. I hope I'm audible. I'm Dr.
Yes, you
Yeah.
are.
Soumya. I'm a child and adolescent psychiatrist, so I have some experience working in liaison psychiatry with pediatric populations undergoing both renal transplants as well as liver transplants. So, thank you so much, Dr. Umar. Your talk was really wonderful about the various aspects of counseling and the way it has to be done. I just wanted to share my thoughts about my own experience of counseling children who undergo transplants. And I think a lot of times when we are looking at younger children, I literally have taken them and showed them the OT setup, and they have a lot of anxiety about how the whole process is going to be. That's one thing, but I think the bigger anxiety for them many times is about the difficulties they face in their own minds about what would happen to the donor, because many times the donor is either the father or the mother or somebody really close in their family circle, and for them to not have that parent figure when they are also recovering, and that fear of what if something happens to them in the process of them donating a kidney to me, I think that's like one of the most important mental health problems that I have encountered while you know pre-transplant counseling sessions when I have for the children. And many times parents are very confident about the transplant and the complications, but I think children have that immense fear of losing that family member, or them going into some complications. So I've also used stories and art therapy, poetry for some children who are really young, animation videos and things like that, for them to understand the whole process. So it was really wonderful to hear your talk comprehensively, sharing about how and what are the steps of counseling. Thank you so much.
Yeah, thanks a lot for bringing this up. That it's very important that the child is separately addressed in the way they would understand, and with pictures and videos, etc., about the transplant process, what is going to be happen to them, how they'll be looked after, how they may have to spend a few days without their parents, so that they're not shocked and have at that time. And that's an important part of the whole process, explaining to them what's going to happen and reassuring their fears. Thank you for bringing it up.
Any other question? Please unmute
I think
yourself.
there was one question on whether we can use adult kidneys for children. It
Okay.
is usually an adult kidney. Okay. If you're listed in the cadaveric list, then if you happen to get a pediatric kidney donor, it'll preferably go to a pediatric patient, at least in Maharashtra, because these rules change from state to state, and I would maybe a little different in each state. But if it is an adult, if it's a live donor, it's always an adult. You have to be above 18 to give consent. So it is a large kidney in a smaller child, and that has its own kind of challenges, both surgically and nephrologically, but they can be managed. Most donors are like that. Yeah. There was one more question, I think, about the finances.
Mm-hmm.
I don't think we
Especially
can
to do
run
with the
away from
immunosuppressant.
discussing. Yeah,
Yeah.
yeah. It is a very important part that they have to know that the financial need does not end with the surgery alone and would need ongoing for the medications, for the tests which they need to do, for the repeat visits which they may need to make to the doctors, which initially may be frequent, and an occasional need for hospitalization. So this one has to give an idea that these are the things that would be needed.
Somehow, the parents manage to raise funds through crowdfunding and so many other routes. But it's always the post-transplant immunosuppressant medications. How do we raise funds for them? And they keep coming back, and then they run into a wall. So these are the challenges. Any other questions? Pallavi, any question?
I think it's a very good session. Really enjoyed listening to you, Dr. Ali.
Thank you.
Can't be easy working with children and their parents.
Yeah, and I've heard such wonderful feedback from parents who have their children treated by Dr. Ali. She explains in such a nice manner. The kids feel so much confidence. I think we need to emulate this. Very important.
Prakash,
Prakash says we have.
why don't you
Yeah,
unmute
why don't
yourself
you?
and ask your question, Prakash?
Yeah, Prakash Lobo, can you please unmute yourself?
Hello, am I audible,
Yeah,
ma'am?
Yes.
yeah, we can hear you. Yeah.
Thank you, ma'am, for that wonderful session, ma'am. I have one case, ma'am, where we have facing a lot of challenges like ethical dilemmas. We have identified a lot of social psychological issues with this family, who is a probable child who is planned to undergo kidney transplantation. This baby is 4 year old, and mother has voluntarily come forward as a kidney donor. But the currently all the medical workup is going on, ma'am, and simultaneously legal workup also going on, all the paperwork. What is the issue we are facing here, ma'am? The family is significantly going through a lot of psychological social issues because there another child who is having a seizure disorder, who is always has a there and here faint, and also this baby is on CAPD. So for almost 12 to 16 hours a day, where the CAPD has to be done, and the mother is a kidney donor, and also she is the breadwinner of the family. So a lot of the time, because of all the psychosocial related issues, stress, this family is non-compliant with the medication, non-compliant with the dialysis, and knowing all this, despite of all that, since the family has come forward and the donor has voluntarily come forward, we have initiated the transplant process. But the issue where we are facing here is, they are even after all this, they are been non-compliant, and they promising us that they'll be compliant after transplant. So it is like a dilemma where we are in, where we have identified that the baby's father is a caregiver, and also he has a lot of psychosocial related and aggressive behavior. All these are issues are identified in this case. So the issue right now we are facing, they are promising us they will be compliant after transplant, like immunosuppression, they all will take. But we have a fear, as we know that even after transplant, even one dose of missing, there is a possibility of rejection, all those risks. So this is the challenges we are facing right now.
I think these are all very challenging situations, where every family you have some aspect which
Yes.
challenges you. You don't get a ideal, perfect kind of family setup in this. And also there's so many different kinds of crisis and relationship stresses people go through.
Yeah.
So maybe somewhere you'll have to use your best judgment to see whether they're habitual defaulters or they're defaulting because they're overwhelmed with what they have to do. Like if the father has some problem and mother's doing everything, and it's not so easy to do, the CAPD along with all the work you're doing. Maybe she's missing out because she just doesn't have the time. That may not be the same in a transplant where all that she has to do is to make sure she gives the medications on time, follows the instruction regarding diet, and come periodically for checkup and do the tests, which may be much easier on them. At the same time, if they are kind of people who habitually kind of disregard advice and do their own thing, then they may be a high risk for transplant. So you could have two kind of situations here, which you may be forced to kind of take help maybe of some psychologist to see what is the problem and get more understanding of the attitude and motivation.
In general, Dr. Ali, I would think CAPD is tougher for children as compared to hemodialysis, right?
Yeah,
A,
because baby is just 4 years, so hemodialysis is an unlike option. So CAPD is a likely option. So we have motivated them, and they opted for the CAPD option also. But with considering the transplant, we have referred them as a family to the psychologist, psychiatrist, all. So they have gone. The family has gone through a number of sessions with the psychologist as well as the psychiatrist. What their opinion is, clinically they have not identified any diagnosed anything. So it is more of like what they are going through, the stress because of the situation and situational stress. So and they are also, they have told us that probably just because the current stress what they are going through, it is we cannot abruptly say that they will not be compliant after transplant. It can be a situation, the current situation. Probably they can, if the family says they have to go for want a transplant, then as a treating team we cannot uh, go
Yeah, because
against
from
them.
what you're saying, the family has genuine problems of continuing with CAPD.
Exactly.
I would always say that CAPD is more difficult than HD because coming thrice a week to the hospital, spending 4 hours,
Yeah.
traveling, if you're in Bombay, or at least traveling 1 hour, going 1 hour,
anyway,
coming.
yeah.
That
Yeah.
means you're losing your job, your other children, if you have another child, you have to
Mm.
rely on somebody else to look after if the mother is accompanying. So HD has its own challenges. I think both are difficult. We cannot
True.
really. So it's
True.
more like the family is suited for which better. If they
Mm.
don't want to take up too much responsibility on themselves and are happy for the dialysis department to take care of it, and the coming and going is not the biggest issue in their minds, then HD would definitely be a better
Sure.
option.
Thank you. Any other questions? Or we can close the session. All right. Thank you so much, Dr. Ali. Uh, your
Yeah.
insights have been really wonderful. Thank you so much. This will help all the coordinators, I'm sure.
Thank
So
you so
thanks a
much.
lot for your time. Thank you.
Yeah. Thanks, everyone, and thank you, Jaya, for inviting me. Yeah.
Our pleasure. Thanks a lot.
Thanks a lot.